they really have to be both in most cases. I mean, obviously there are some things that are different, but buspirone is a good example of a medicine that's fairly light, that helps people just take the edge off just enough so that the counseling can work. Okay, so that they can learn the things that they need to and have enough of the edge taken off so they can get through it. Okay? Now, that's in contrast to benzodiazepines, which you may or may not have heard of. If you haven't, you will a lot in farm. Is if somebody has severe anxiety problem, benzos work pretty well. So much so that there's a bit of a danger of not recommending a person gets mental health treatment too. Okay? Just don't give somebody benzos and send them on their way. That's, again, not really great practice because they're feeling better, probably sleep better.
Are these highly addictive?
But they're highly addictive, right? They're not meant to take every day in most cases, unless somebody's seriously jacked up, okay? You don't want to have somebody take these things all the time. They're occasional, okay, to stem down some kind of major problem. Yeah?
How do these work? Do they work by like affecting serotonin or by like inhibiting production?
Benzodiazepines? You know what? It's funny, somebody else asked that earlier. I haven't had a chance to look it up yet. I need to look it up. It's just been so many years since I looked at the mechanism of action of benzos. I just honestly don't remember right now. But I do want to look that up. The antidepressants usually have something more to do with serotonin. And benzos are, I can't remember right offhand. But I'll look it up, get back to you on that one.
Oh, what is the beer criteria?
The who?
The beer, the beer criteria. It's in your lecture.
In my lecture? Oh, well, I don't know. What Dr. Wooden wrote those. What does it say?
It's basically for beer. Wait. I think it has something to do with like not giving people this based on that acronym or that mnemonic. I'm sorry, the mnemonic.
So the beer mnemonic. I don't know, what's it say?
Let me read it real quick. So, because I read it last week, so let me make sure.
Has anybody read that knows what she's talking about?
Where is it?
I don't know.
BER criteria.
Oh, probably Google it by the time you finish reading that.
I'll Google it.
Okay, we'll get back to that.
Okay.
All right, let me move on to antidepressants in general. Okay, obviously there are a lot of different kinds of antidepressants. Okay. Notice antidepressants are also used in anxiety disorders. Okay. And the reason is because of serotonin. Okay, serotonin is your neurotransmitter that it keeps your emotions in check. Okay. Serotonin is, again, you can get stressed, you can get depressed. Serotonin will kick in to try to tampen that down, to make it so it's not as bad. Okay? There are people out there that, for example, need some kind of SSRI or selective serotonin reuptake inhibitor, and everybody around them knows they need it, but they don't know they need it. Okay? Because of like 0 to screaming in like a half second. right? Their serotonin levels are not where they should be, okay? And some people are simply born like that. It's like anything else. People are different. Some people have less. Yeah. Is it something you can find in a lab report? You know, I don't know that. There might be, but as far as I know, there's no lab test you can test somebody's serotonin levels specifically. Although you'd think there would be, yeah.
Why do antidepressants make people so sick? Like
Sick?
nauseous? Because I was taking it for a nerve problem before I can get Lyrica, and it made me nauseous, dizzy, like.
That
I
sounds
was
like an overdose.
down.
It does sound like an overdose, but
It says on there, like, causes problems with nausea.
everything that you put in your mouth as a drug can cause nausea.
Everything causes nausea.
It really does. I mean, it's literally, if you look at any drug of any kind, it will have on the list nausea and vomiting because it does in some people. I don't know why. Nausea is a weird thing. It really is. I mean, yeah.
So Beer's criteria is for inappropriate medication use in older adults, commonly called Beer's List. It's a guideline for healthcare professionals to help improve the safety of prescribing medications for older adults. They emphasize medications that are unnecessary and will help reduce problems of pharmacy, drug interactions, and adverse drug reactions. And benzo was on the list. It wasn't in there, it was just on the list, and so.
Okay, the problem with benzodiazepines in older people, elderly, is there is some research that says it can completely destroy your stage 4 sleep, the deep, deep sleep.
The REM.
And what you don't have, elderly people already don't sleep very deeply. Benzos can destroy what little bit they have of the ability to sleep deeply in elderly people. So yeah, that's definitely an issue. I wasn't aware there was a mnemonic for that, but yeah, don't do that as a rule. Okay, now, some things about these SSRIs that you may have heard of, okay, is that like SSRIs, Prozac, right? Fluoxetine, Effexor, Zoloft, a whole bunch of them. I mean, they're the common ones that you hear about all the time. You hear all sorts of things about them, okay? One of the major concerns, of course, is when you hear they cause people to commit suicide. All right, here's kind of how that came about. Is that the Napoleon, okay, it's kind of like this. Where are you going with this? All right, Napoleon, you know, the French leader?
Yes.
Emperor, whatever he was. He had this saying that basically says, keep the peasants' faces in the mud, because if you take their foot off their head, let them look up, they will realize how bad they have things and rebel. Okay? Whether he really said that, I have no idea, but that's what I heard. Okay? So, it's kind of like that with antidepressants, is that the loading dose, the amount of antidepressant medicine you give somebody, is say is right here, that much, right? Well, the effective dose is way up here. So you give them a pill, and then they take it, and then the next day they take another one, and it raises their blood level a little more, and then the next day, and the next day, and the next day. It can take up to 6 weeks to finally get to this level that's effective. Problem is on your way up, they're less depressed, but not all the way where they need to be. Okay? When somebody has major clinical depression, for example, they are unmotivated, let's say. They do not want to do anything. They are too tired, too exhausted, too apathetic to get out of bed, to go grocery shopping, to take a shower, they're too tired to kill themselves. They're just not motivated enough to even do it, even though they may want to. You you start treating somebody for that and giving them the meds, until they hit that therapeutic dose, now their head's out of the mud. Now they have enough energy to get up and kill themselves. Does that make sense? So again, it's kind of important to keep an eye on them, especially for that first 6 weeks, to make sure that they're safe. Okay? Now, as far as what serotonin, these SSRIs are doing, okay? Again, if serotonin is the drug that keeps people from getting too out of control, whether that's anxiety or depression, then what's going to happen is if in your, what is not working? Now it's working. Okay, in your terminal end bulb here, you have your serotonin, and it's released into that synaptic cleft, and it goes into its receptor on the other postsynaptic neuron, right? And it's sending that signal of calm down. That's basically what serotonin does, is calm down. Okay, whether it's depression or anxiety, it's calm down. Okay, once it does its job in that receptor, it sends that message, it leaves and goes back into its synaptic cleft, where there's some kind of enzyme, just like, remember we were talking about myasthenia gravis, and I said I'd get back to that? Well, there's an ACE enzyme that takes care of serotonin also, just like that. Okay? Well, it's going to break that serotonin down and recycle it, shove it back into the bulb, right, to be used again. Well, somebody with a deficiency of serotonin, you give them those SSRIs, the selective serotonin reuptake inhibitors. Again, it is inhibiting the reuptake of serotonin, right, by getting rid of that enzyme that breaks it down and uptakes it back in. So if you inhibit that, you're not giving the person anything. What you're doing is you're inhibiting an enzyme that would break down the serotonin that they're naturally making anyway. Therefore, you have more serotonin available hanging out for when a receptor opens, it jumps in, okay? And it keeps the levels more normal, okay? For people that biologically just don't make as much as everybody else, okay? That in and of itself, I have absolutely no idea why it would cause nausea and vomiting, right? All you're doing is restoring them to the levels where everybody else in the world's at. But nausea is a weird thing. It's hard to predict, and somebody is always going to have nausea no matter what drug you give them. Okay? But that's how SSRIs work. Again, the Zoloft, Prozac, there's a myriad of them. There's just a ridiculous amount of them. Okay? Yeah, you'd probably use it for more severe major depression, but you'd use any of these for major depression. They're not technically addictive. However, there is one, Effexor. I believe that's the fluvoxamine. Maybe not.
No, it is. You're right.
Is it?
Mhm.
Effexor. That one, you know how it took 6 weeks to build up in your system? With any of these SSRIs, they don't recommend that one day you just stop. Because if you do, especially with Effexor, you'll probably go through a little bit of withdrawal. As in, you'll start breaking out in sweats and shaking and feeling like garbage.
Isn't that called a serotonin syndrome? Or?
Yeah, it's called serotonin syndrome.
Okay.
Technically, they're not addictive. However, if you just cut them off, you're going to feel the effects. So that's not a good idea either. Okay. Anybody have any questions, comments about any of that? Yes?
Are you going to be tested on drugs?
You'll be tested on drugs in pharmacology when you get to nursing school. I'm not going to test you on drugs. But, trust me, when you get to pharmacology, the last thing you want to do is learn everything, and that's the first time you're seeing it. It's kind of the whole point I mean, you get patho in nursing school too, but